Wealth is defined as things people own and use to produce goods and services, enjoy directly without consuming them in the process. Examples are land, natural resources, and shares. Wealth is distributed in different ways that reflect composition, such as land resources, produce capital, roads, bridges, or location, such as between nations, regions, cities, neighborhoods, and households, or sector, between public, private, and household, and ownership that reflects the distribution of individual private wealth. Wealth is not the same thing as income. Income is about flow of money, whereas wealth is concerned with holding a stock of assets. Obviously, there are strong links between levels of income and wealth, but income is not an adequate substitute for understanding the distribution and dynamics of wealth. The patterns of distribution of wealth globally have huge health impacts, but they have been largely invisible and unnamed in both broader social science and public health specifically. There are two crucial ways in which wealth affects health status. One is the distribution between people of a country's stock of marketable assets and concerns the wealth of people. The other is the distribution of global wealth between countries and concerns the wealth of nations. Increases in income have been particularly sharp at the top of the income distribution. Some 46% of the total increase in income between 1988 and 2011 went to the wealthiest 10%. Since year 2000, 50% of the increase in global wealth benefited only the wealthiest 1% of the world's population. Conversely, the poorest 50% of the world's population received only 1% of the increase. Global wealth has become far more concentrated. The wealthiest 1% of the population had 32% of global wealth around 2000 and 46% around 2010. The super rich, the wealthiest 0.1%, loom larger. The share of national wealth among the super rich in the United States increased from 12% in 1990 to 19% in year 2008 before the financial crisis, and even to 22% in 2012. Critics pointed to the inequality as one of the key causes of the crisis then. There are very little data on the distribution of wealth between persons within countries. This seems to be because reliable wealth data are elusive. Unless countries have a wealth tax or ask questions in the national census about wealth, which most do not, the information is simply not available or is not very reliable. This graph provides an illustration of the relationship between health and social problems with income inequality, which is measured by the ratio of incomes among the richest compared with the poorest 20% in each country. It shows a cross-sectional association between income inequality in developed countries and an index which combines data on life expectancy, mental illness, obesity, infant mortality, teenage birth, homicides, imprisonment, educational attainment, distrust, and social mobility. Improvements in life expectancy in the United States have been matched by similar improvements in other rich countries. Indeed, there has been a rapid convergence of older adult mortality rates since 1970s in rich countries, particularly among men. Outside of the rich countries, average health is strongly correlated with income. As shown in this Preston curve, countries are represented by circles, and the size of the circle is proportional to population. Life expectancy is profoundly lower for countries with lower levels of per capita income. The reduction in mortality was not uniform by age. The vast bulk of the historical reduction in mortality occurred at younger ages. In this figure, it shows trends in life expectancy by age in England since 1840. Between 1841 and 1950, life expectancy at birth increased by 30 years, while life expectancy at age 10 increased by only half of that amount. The decline in infectious disease explains this disparate age pattern. In 1848, 60% of deaths in England were from infectious disease. Between then and 1971, infectious disease mortality declined by 95%. Since infants and children are the most vulnerable to infections, their mortality rates were not affected by the decline in infections. The source of the reduction in infectious disease mortality have been extensively debated in the demographic community. We have identified a number of factors which improve life expectancy. First of all, we have improved nutrition. Direct evidence on the role of nutrition in improved health and mortality reductions comes from the work of Robert Vogel in a series of papers summarized in his 1997 paper and then in his year 2004 book. Vogel begins by showing the enormous increase in caloric intake after the middle of the 18th century, measured by both directly from agricultural output and diary surveys, and indirectly through changes in adult height. Nearly all the reduction in mortality from the late 18th century to the late 19th century can be attributed to improved nutrition, as well as half of the mortality improvement in the century after that. Second, public health. Macro public health involves big public works projects, filtering and chlorinating water supplies, building sanitation systems, draining swamps, pasteurizing milk, and undertaking mass vaccination campaigns. Micro-public health involves changes made by individuals but encouraged by the public sector, including boiling bottles and milk, protecting food from insects, washing hands, ventilating rooms, and keeping children's vaccinations up to date. Macro public health was always present to some extent. The third factor is urbanization. Urbanization was not good for health, at least initially. The preponderance of the evidence suggests that the lack of improvement in mortality between 1820 and 1870 was due in large part to the greater spread of disease in new and large cities. The effect of unsanitary conditions was larger, and the spread of disease was easier in bigger, more crowded cities. However, when urbanization develops, the technology and expertise of medical treatment concentrates in urban area that leads to further improvement in population health, and therefore the life expectancy increase in urban areas. The fourth factor is vaccination. Vaccination was introduced by Edward Jenner at the end of the 18th century, but wide-scale research on vaccines depended on the germ theory of disease and did not occur until a century later. Since the late 19th century, there have been a number of new vaccines. The morbidity consequences of these diseases were high, but the best available historical data suggests that in the now rich countries, direct mortality from these diseases was relatively rare immediately prior to introduction of these vaccines, except for tuberculosis. As many as 500,000 people contracted measles in the United States just before the vaccine was developed, for example, but measles directly accounted for fewer than 1,000 deaths. Exclusive of tuberculosis, reductions in these causes of death account for only 3% of the total mortality reduction. Medical treatments definitely has a role to play. More intensive medical interventions date in importance largely from the post-World War II era and are associated with a different cause of mortality. Since 1960, cardiovascular disease mortality has declined by over 50%, and cardiovascular disease mortality reductions account for 70% of the 7-year increase in life expectancy between 1960 and year 2000. Academics matches the results of clinical trials to actual mortality declines and attributes the bulk of the decline in cardiovascular disease mortality, such as 2/3 of the reduction, to medical advance. Beyond medical advance, the majority factor in reduced cardiovascular disease mortality is the reduction in smoking. An additional 19% of the increase in life expectancy since 1960 is a result of reduced infant mortality. Academics attribute a large share of continued infant mortality reductions to improved neonatal medical care for low birth rate infants. The remainder of the decline in mortality since the 1960s includes reduced mortality from external causes, primarily motor vehicle accidents, reduced mortality from pneumonia or influenza, and a slight decrease in cancer mortality. The last factor is the long-term reach of early life factors. fetal origins of Barker posits that in conditions of nutritional deficiency, the developing fetus will differentially compromise functions that are operative only late in the life cycle, beyond the normal age of reproduction, thus maximizing the chances of survival through reproductive ages and the number of offspring. The consequence for modern population is that better nutrition decades ago could be having its effect only today. Childhood factors such as nutrition and the decreased environment have the potential to significantly affect mortality at older ages, although the magnitude is open to some debate. For this reason, some of the decline in mortality at the end of the 20th century might be attributable to improvement in diet and public health many years ago, with the possibility of still some more improvement to come. Researchers have identified the evidence showing the effect of wealth on health. For example, homicide and inequality were positively associated among states in the United States back in 1974. In 1979, a cross-sectional association between Gini coefficients of income inequality and both infant mortality and life expectancy at age 5 among a group of 56 developed and developing countries were shown. In 1993, it was found that a robust tendency for violence to be more common where income differences were larger. And until recently, the correlates of inequality included teenage birth rates, obesity, and mental illness were found. Snyder's analysis of the distribution of wealth shows that wealth distribution has been persistently unequal. The figures he reported differ somewhat according to the method of calculation, but in all the countries for which he has data, the States, Sweden, Australia, Canada, New Zealand, France, West Germany, and Belgium, the top 10% of people have held at least 50% of the wealth over the 20th century, and the percentage is often higher. A general pattern is that wealth inequality seems to have declined in the first 7 decades of the 20th century, but has started to increase from the 1980s and more so in the 1990s. A similar pattern of unequal distribution of wealth exists in each country that Snyder considers. There are some differences in the trends in that Sweden seems to have become more equal in recent years. Despite the paucity of good quality and consistently measured data, which is available suggests that the distribution of wealth is more unequal than the distribution of income, and the Gini coefficient for the world distribution of wealth is estimated to be at least as high as 0.9. The health consequences of this distribution are likely to be massive, but are as yet uncalculated. From a public policy point of view, recent evidence of growing polarization is worrying. The political economy of health has also paid only passing attention to the issues of wealth and the wealthy and has concentrated most attention on poverty and the poor. Yet there are pieces of evidence that suggest public health could advance its overall project of improving population health in an equitable manner by studying wealth more directly. Countries such as those in Scandinavia and Japan have achieved comparatively more equal wealth distribution and also have higher life expectancy than countries with higher overall wealth, but more polarized distribution such as the United States. Work on well-being and health shows that increasing health in rich countries is not necessarily leading to more happiness. Research on health inequalities is producing more and more evidence that hierarchies are bad for population. Marmot and colleagues found a steady gradient in the rates of death between the lowest and highest ranks of the British civil service. The main features of his findings were that the gradient was continuous, and that only a third of the effect vanished when lifestyle influences were accounted for. There is also a body of evidence on the impact of distribution on income within countries on average life expectancy. The data are somewhat inconclusive, but do show that such macro-level analysis is related to population health outcomes. A recent review of the evidence by Lynch and colleagues was noticeable in that no studies of wealth distribution were revealed. Finally, there is a body of evidence from developing countries that shows that achieving high levels of population health does not necessarily require high national wealth. Cuba, Sri Lanka, China, Kerala State in India, and Costa Rica are all examples of places where high health has been achieved despite the fact that they have much less wealth than other countries. Analysis suggests that such achievements result from social investment in literacy, education, protecting the livelihood of small farmers, good primary health care services, and meeting basic needs. These factors add up to societies where social solidarity and the goal of egalitarianism are favored over an ethic of individualism, which is more strongly emphasized by neoliberal regimes. The importance of these studies is to show that achieving a decent standard of living for all the world's population is primarily a question of the politics of distribution, not of insufficient resources. Recent evidence from China suggests that as the more egalitarian regime gives way to a more capitalist enterprise, disparities in health and economics are increasing. The epidemiology of wealth that is available suggests that in the period of growing welfare investment by states, wealth distribution becomes a little more equal. By contrast, the past decades of rampant neoliberalism with the concomitant withdrawal from welfare seem to have increased inequality in distribution. There is currently very little understanding of how the huge disparities in income and wealth between rich and poor countries themselves contribute to the massive health inequalities that see 20 to 30 years life expectancy difference between those in rich and those in poor countries. The conclusions from rich country research that being lower down in a hierarchy is stressful to the body and so has an impact on life expectancy must surely affect these massive health inequalities between rich and poor countries. And yet the global social relations stemming from unfair resources distribution and trading patterns have not been researched. What is the public impact of consumption patterns created by egregious wealth on diets, the use of fossil fuels and of water, for example? There is an emerging body of evidence on the impact of unfair trade practices on the health of people in poor countries, and a growing civil society protest against unfair trade. While some research attention is being paid to the ways in which rich countries establish financing and trading structures to maintain their privilege, such as the International Monetary Fund and the World Bank, there is scope for much more research of this type. Building an evidence base on wealth and health, and on understanding the dynamics of underpinning the distribution of wealth and health, could be complemented by policy research that considers what healthy public policies seeking to redress undue concentration of wealth might look like. This research could consider comparative analysis of social attitudes towards wealth and social solidarity. The current extreme disparities in wealth, both within countries and between countries, can continue to exist only because there is general ideological support for it. Clearly, there is a need for research into the function that wealth and income inequality played in the global economic system. The acceptability of equal wealth distribution differs from society to society and from one time period to another. Studies of the conditions that bring about relative equity would be valuable to understand how redistributive policies can be achieved. Part of the ideological support for the acceptability of large discrepancies in wealth must be, in part, be explained by the need to encourage widespread consumerism. Further research could also analyze taxation policies on income and wealth from a public health perspective. Consideration could be given to the potential public health impact of general wealth tax, capital gains tax, capital transfer tax, and death taxes. The proceeds from these taxes could be invested by the state in infrastructure such as publicly funded health and education services that would act to reduce health inequities over the longer term. Economists have long been in the habit of discussing and analyzing public goods. A public good is not something that is good for the public, although it can be, but a precise piece of economic jargon. It has two key properties. Non-excludability, meaning that it is not possible to prevent the use or consumption of the good by some category of people, such as those who have not paid for it. And non-rivalry, meaning that for any level of production, the marginal cost of providing the good to an additional consumer is zero. In both cases, the role of price in regulating the balance between supply and demand breaks down. Classic examples include law and order, defense, and lighthouses. Left to the free market, public goods will be greatly undersupplied because of their non-excludability and non-rivalry. Governments everywhere must therefore step in to finance, subsidize, and/or supply them. This is one area of public responsibility that is not contested even by the most radical free marketeers. In medicine and health, factors that cause widespread environmental damage with negative consequences for health are public bads, and their reduction is a public good. Obvious examples include ambient air pollution, global warming, and ozone depletion. Ambient air pollution typically occurs in a restricted area within one country, such as Delhi, Lagos, or Mexico City. The government therefore intervenes by regulation, taxation, or other means to provide a public good, that means cleaner air, that individual citizens cannot buy for themselves. Where air pollution stretches across national borders, such as in the former East Germany, the Czech Republic, and Poland, the affected countries may cooperate to reduce a public bad from which they collectively suffer and to which they collectively contribute. Global public goods have recently become fashionable for particular health objectives. However, the term has been widely misused, as if it means anything that is good for the health of the global public, rather than its precise economic definition with clear implications for finance and provision. An example is the control of communicable disease on a worldwide scale. Many of the international community's aims in this field have the characteristic of a global public good, such as disease eradication. To fit the definition, the benefits must be enjoyed by all countries in perpetuity, even if they have contributed little, financially or otherwise, to the campaign. The concept of global public goods for health suggests two lines of argument that are becoming increasingly commonplace. First, the great majority of official development assistance, commonly called aid, from wealthy countries to poorer ones, has focused on specific projects that benefit specific groups in specific countries. Only a small fraction of the funds has been spent on investment in global public goods, which arguably have had higher returns and a greater success rate than project-by-project assistance. The second argument is that global public goods for health, particularly the control of communicable diseases, should be removed from official developmental assistance. Preventing the rise of these diseases is not a matter of charity from rich countries to poor ones. It is a global collective enterprise from which all countries should benefit. Just as the United States invests in its Centers for Disease Control and Prevention (CDC) in Atlanta for the national good, so the world needs to invest collectively and strenuously in practical controls for infections, in slowing or preventing the development of antibiotic resistance, and in research into new drugs. The international surveillance of flu strains and regular production of new vaccines against the disease on a regular basis are good examples of a successful collaboration for global public good, although it mainly benefits wealthy countries in which flu vaccines are most widely used.